A warm welcome to A Nurse's Lift to Work with Tina and Kate, coaching podcast by two healthcare professionals. We are friends, we are nurses, master NLP coaches, hypnotherapists, parents and business owners. We are busy people juggling many things just like you.
You are in for a treat. We will chat about informal coaching tips, coping strategies, and how to effectively change your mindset and have some fun along the way. So, hop on board with us for A Nurse's Lift to Work. Welcome to A Nurse's Lift to Work with me, Tina.
And I'm Kate. Hello, everyone. Tina, today's topic.
Well, it was offered to us by somebody in the Perceptric Facebook group called Helen, and she suggests that we might want to talk about why people get labelled as difficult patients and what we can do about them. I suppose we could include difficult families in that topic as well.
It's always a bit of a contentious term, difficult as well, isn't it? Because when you get that label, it's really difficult to
shake it off. And we give other labels sometimes in clinical situations, like, oh, she's such a poppet, and that, oh, she's a darling older lady, and all that stuff. So you've got a range of labels, and so labeling full stop period is probably something every clinician should have a good old think about, whether that's appropriate and whether they would wish a label to be applied to themselves. But for the instances of this conversation, we're chatting about the label that's difficult patients, which I'll pop a link into the show notes, but we found a nice little article from the BMJ, and they title it Managing Challenging Interactions with Patients. So it can get these different labels, which perhaps feel a little bit more clinically comfortable.
Yeah. What do we... I think it's important that we address what do we mean when we say a difficult patient, and it's important to think what it means to you, because obviously we've each got our own different approaches to this. But what is a difficult, in inverted, I am using inverted commas, a difficult patient?
Well, good question, isn't it? Is it somebody who gets that label because they are assertive and they are somebody that we find it challenging to go and have a conversation with? Is it that they take up a lot of time? Is it that they have been aggressive in the past? And we've done a recent episode on when you get assaulted at work. So, is it something that comes out of the fact that something has genuinely happened, an incident? There are reasons that spring to mind for me. What about you, Kate?
Yeah, so for me, it's the demanding, I suppose. I think demanding patients, those who shout and want things,
Ring their bells a lot.
Yeah, but it's interesting, isn't it? Because when we talk about, listening to you talk about all of those situations and all of those different scenarios, it's not about the patient at all, is it? It's about our perceptions and how those situations make us feel and respond.
Because is the problem that's perceived here, like the difficult patient scenario, is this the patient? Are they genuinely hostile, disruptive, unpleasant? Is that a genuine thing, or are they afraid and therefore they've got these behaviours of wanting a lot of reassurance, i.e. I'm ringing the bell a lot? Have they got continence issues and fearful of having been incontinent? So do they ring the bell a lot because their lived experience of the last time they asked for a commode, it took 35 minutes to get to them through nobody's fault, but it did, and therefore they were incontinent, and are they fearful of that, about their pride, their dignity? So, sometimes it's a little bit of unpicking here around what the patient is actually doing that's contributing to this label.
Yeah. I'm going to tell you a story. And this isn't about a patient, this is about a relative. And I might have said this scenario before. I was working in a community hospital and I was looking after my caseload of patients. And at handover, I was told, watch out for bed X's daughter. She's really difficult and rude. So what's my response going to automatically be? Like, oh, all right then.
You'll be on guard, won't you?
Ready for a fight. And when the patient was lovely, no problems, it's all good. And when the daughter arrived, she was rude, like, woo! I had met her before, and I took a deep breath, and because sometimes, listeners, you need to take a deep breath. Whether you like your next course of action or not, you've got to take a deep breath. And for me, it was like, right, we're going to have a chat. So I said, I'm really sorry. I said, we've not met before. I said, let's have a chat. And I told her how her comment and the way that she spoke to me made me feel. I said, so let's have a chat about it. And it turned out that despite the daughter was doing everything she possibly could to get her mum home. The mother had awful care in an acute setting, and she wasn't listened to. She wanted her mum to mobilise and get around and get better, but we weren't giving her any physio. So she asked if she could pay for private physio to come in and give physio for her mom so her mom could get better. No. No explanation. No. I'm like, okay. She wanted to bring in a bariatric commode from home so that it was easier for her mom to mobilise to the toilet. No. But no explanation given. Like, and I sat down and I was like, I'm here, I am listening to what you're saying. And it was awful. I'm not going to lie. The things that she was saying, I was mortified that the treatment that they had received was the treatment that they got, because, that's not what we're about. It's about the patient and what's the best thing for the patient. And sometimes we don't know that. Relatives know that.
Yes, and they are the expert in themselves and their lives, and we are the expert in clinical care. And what you've highlighted is sometimes the problem is not the patient or the family, it's the doctor, the nurse, the clinician. So if the practitioner's hungry, angry, late, tired, or personal factors, maybe they've just had a pring in their car on the way to work, or their dog died yesterday, who knows? But they're just not in the headspace for being really empathetic.
No.
And so they're going in a gruff manner. Maybe they went, no. And then the next thing, there's that sort of interaction that you're talking about. So, that if there is a personality clash with a patient, then you might like to think about how easy it is for them to get a stereotype label as a result of that. If you go back to the clinical team and say, Kate, she's just really difficult. So, just be mindful of your own potential role in all of this.
Yeah. And a lot of it is almost a hearsay, isn't it? Just because of that one person, it can change everybody's perception, which is why it's so important not to pass judgment on anybody until you're there, until you're with them, and you can engage in that two-way conversation.
Yeah. I mean, I don't know. I'm sure some of our listeners have been sleep deprived, for example. Maybe if you've got young children, you particularly have, but maybe for other reasons, you might not have got much sleep. And it can make you behave in a very certain gruffly annoyed way, can't it? So some diseases, I mean, the other factor is the disease. So the disease that patient is dealing with might well be taking away their freedoms and their independence. They're adapting to that, chronic pain, or there's ill-defined diagnosis and they just want an answer, what's wrong with me? And everybody's like all over the shop. Or they feel passed from pillar to post, like we can look at your leg and we're the leg department, but you need to be referred to the gastro for your tummy, and then it's gynae for this. And you can feel like a package and less of a person. So, disease processes don't help either, as well as ones that affect your cognition. So, what's the starting place for the patient, really?
Yeah. And I think it's being able to, and having the awareness to actually just take a minute and step back. Now, we know that time is a precious commodity. It really is. And in healthcare, there never seems to be enough of it. But if you spend 5 minutes getting to the bottom of what's going on with one person, in the long run, it will save so much more, because it's not just about the now, it's about the difference that the now makes to what's coming.
Yeah. And some people, if you talk to certain patients, and I'm sure this will happen for a lot of our listeners, you appear at somebody's bedside, is rang the bell, and they go, I'm so sorry to bother you. I know you're all so busy. I know there aren't many of you today. I know you've got that gentleman over there who keeps getting out of bed. Why is that patient knowing that story? They often comes into hospital needing to know that patient, unless I can physically see them. They don't need to know that. They don't need to know how many staff are on duty. They don't need to know that we're rushed off our feet. They really don't need to know any of that. They need to feel safe and well looked after. You might say to somebody, I'm sorry it's taken me a while to get to you. There's just a lot going on here today. But anyway, here I am now. What can I do for you now? But all the backstory of, well, we were 20 minutes, Mr. Smith, because there's only 3 of us and 2 people have gone off sick and that man's doing this over there. It's not necessary. So
I have said that to people before, and the response was, but that's not my problem. That's not my fault. Because it's almost like I was passing either an excuse or a blame onto that patient.
yeah.
No, it shouldn't be like that at all.
And years ago in a community hospital I used to work in, it was a circular setup. And often the healthcare assistants, when patients were admitted, they would show them around the ward just to clarify for them that here you are in a bay of 6, but just for your personal awareness, there's all this other stuff going on here as well. So I'm sure people are considerate of that. And I know patients who really are reluctant to ring their bell, or they wait and they wait and they wait, because they don't want to put the burden of wanting something from a nurse on that nurse.
Yeah.
So, yeah.
Think about your environment and your reactions, because that's essentially what this is about, is your reaction to those situations, to those people, and how you deal with it at the time. Is it something that requires time? Is it a better communication? So you can think to yourself, how can I make this better? And a great question to ask, how can I help? And if you need to apologize for something, then apologize. I'm really sorry that I didn't answer your call bell straight away. I know you must be frustrated, and I am really sorry. So you're acknowledging their pain point. I'll get you to the bathroom right now.
And also set yourself up for success. So I used to have this strategy where if I was with somebody and I'd done something, I would then say, what you're likely to need in the next hour, because I might not be back for a bit. What you're likely to need. And then they'd go, oh, I need my tissues and that from the bottom, and you set them up for a win. Get them comfy, get them everything they need is around them. And then actually, they might not, if you don't do any of that, if you rush in, do the toilet in and rush back out again, they'll be ringing in half an hour for, I can't reach my drink and I need my tissues.
Yeah.
So, and try and occupy, try and suggest that they read or they do something, or so they're not just waiting for whatever they're waiting for.
I think another important consideration is the cognitive function of that individual. If they're new to your environment and you don't know them, but it's a real scary place. So how can you get to know them better, to know what they like, what will settle them? There are, do they need a twiddle muff or other fidget device to keep them calm? So it's sometimes thinking about the bigger picture. Or have you got somebody who is normally okay, but all of a sudden they're not, they're like "Rrr," and just being different, like a personality change. Why has that happened? What has happened between then and now to cause that change? Is there an imbalance somewhere? Is something going on inside that's created this change? If you do notice that, it needs escalating.
Yeah, and it's part of the assessment process, isn't it? Of like, is that coming from a physiological place? Is that coming from another kind of place? And yeah, if somebody's agitating and coming out of their room a lot, they are free agents. And
You will stay in your room and you will not move.
you'll not leave your room. And they're not like chess pieces. They're not going to be where you put them when you found. So if somebody is moving around, just think, well, what would I do? Would I want to stretch my legs? Would I want to sit in the same chair all day long? Or if I was confused, maybe I could come and sit by the desk and tidy out a drawer. Like you say, ways and means to kind of see it differently. But sometimes, Kate, I think if I look at my own family and I include myself in this, how many of us would be labelled as a difficult patient?
Oh gosh, I would be up there.
Yeah, I expect I would be as well because I've got lots of questions.
And it might be I'm a watcher. I love watching people, and that can make other health, I'm going to say colleagues, it can make them feel like, I don't know, a bit unnerved. So if you're watching doctors and nurses who know that you're a nurse, are like, oh God, am I doing my job all right? What's like, what, oh God, she's looking at me. Oh.
And I mean, it's a great leveler, but truly, truly put yourself in their shoes if you possibly can, and look for that empathy that you probably, on a good day, have got spades full of that. Yeah.
Yeah. And on that note, my lovely Tina, I hope that actually, I know that we have given you some really useful tips there, just different ways of thinking about stuff. So take it and remember all of this information that we give you, all of these handy hints and tips mean nothing if you don't put them into action.
So next time you're in a handover and somebody refers to somebody else as a difficult patient, just pop a thought in your mind about this podcast and see what you could do differently.
Yeah.
Thank you, everybody. This is Tina.
And I'm Kate.
And you've been listening to A Nurse's Lift to Work. You've been listening to A Nurse's Lift to Work with Kate and Tina. Please remember, this is not a replacement for medical treatment or help, so do seek assistance if you need to.
Thank you for joining us. Please do like, subscribe, give us stars, like and share with your friends and colleagues. All the good things.